And so for me personally, this is my aim as an ophthalmologist. This is why I left clinical practice to come into the industry, to really help move the whole platform forward in whatever way I can personally, to be able to get these treatments out there for patients. Our goal, our common goal for all of us, is to be able to get treatments there so that we can prevent blindness happening for these patients. And so we hope that we're one step closer with these trial results so far. Good morning, everyone. It's my pleasure to be able to present to you this morning the QR41A interim stellar trial results. My name is Aniz Girach. I'm an ophthalmologist by trade. I've been with ProQR for over 2 years now, and I'm the Chief Medical Officer for ProQR. So, of course, there's forward-looking statements because we're a NASDAQ traded company. So just a quick recap on QR41A. This is the drug which is known as an antisense oligonucleotide. And that essentially is a form of RNA therapy. And this is the drug that's been used in these particular trials. Now, RNA therapy is a variation of gene therapy, but not quite the same. Whereas gene therapy affects the DNA, RNA therapy affects a downstream molecule called RNA, ribonucleic acid. And that's very important because RNA is a stepping stone towards protein formation within the eye. And specific proteins are very important to be able to help prevent blindness within the eye. And so by having a therapy that could actually work at the DNA level, such as gene therapy, could be very useful. But for us, we think that actually there could be advantages in having an RNA therapy working at that RNA level in order to also help bring forward many treatments for these diseases. And there are many advantages specifically for RNA therapy as well. And specifically, in Usher syndrome or non-syndromic retinitis pigmentosa, patients go blind because there is a lack of a particular protein that's needed at the back of the eye to help the cells at the back of the eye, called photoreceptors, function properly. And QR41A helps to restore a functional copy of that protein at the back of the eye in order to make sure that the retina and the photoreceptors are working properly. And essentially, that's how it does things. And the way that we are able to administer the drug is through a simple injection under local anesthesia to the back of the eye, which is relatively painless for patients. We were very happy to receive some co-funding from the Foundation Fighting Blindness in order to actually kickstart the study as well. So thank you very much to them. We've looked at Usher syndrome and non-syndromic retinitis pigmentosa in a couple of different ways. And a relatively easy way for us to think about this is by thinking of the early to moderate disease, where predominantly you have participants who have vision loss that's occurring by the fields collapsing in. And many of you will be familiar that Usher syndrome and non-syndromic retinitis pigmentosa leads to degeneration of the back of the eye. So essentially cell death at the back of the eye. And that leads to the field loss that you see typically. And that field loss can be progressive over a number of decades, ultimately leading to pinpoint vision. And then unfortunately, even that pinpoint vision collapses. And of course, participants go blind at the end of the day. So the earlier disease is focused on trying to address the issue of visual field loss. This is how much fields, how much vision that you have in the periphery. That will be important to be able to arrest if we can. And then the end stage of the disease is where your central vision, which is measured by something called central visual acuity, which we'll talk about in a subsequent slide, and that even that central vision also collapses and patients go totally blind. It's very important to be able to look at these two stages of the disease, because in these two different stages, we will be addressing different outcome measures that will actually be able to be used effectively to see how well the drug is doing at each one of those stages. And we'll talk more about that in subsequent slides as well. This slide is a visual depiction of what happens in participants who have Usher syndrome or non-syndromic retinitis pigmentosa. In the red line is visual field deterioration. So this is how much you can see in the periphery of the visual field. And as time goes on, as the disease progresses, of course, it presents with dim vision and night problems. And then as things progress, you lose a lot of these fields, such that by the time the visual fields is down to the central 20 or 30 degrees of vision left only, which is like looking through a straw, then unfortunately, your central vision starts to deteriorate as well, which is given in the green line. And it's also depicted at the bottom with some illustrations as well. And like I said, it's important to be able to think about these two in different buckets, because we will be looking at different measures of outcome in the trials that will address these particular two different features of the disease. Now, this slide briefly outlines the trial design, the STELLAR trial design. The STELLAR trial is a first-in-human phase 1/2 trial in Usher syndrome and non-syndromic retinitis pigmentosa. The enrollment is now completed. This is a sham-controlled trial, and it involved 3 different dosages. Typically, participants were included in the study where if they met the eligibility criteria, then one of the eyes got treated with QR-421A, and the fellow or untreated eye was untreated totally. This was a control. And that was the same with the sham participants as well. That the sham participants, one of the eyes had a dummy injection done to them with some local anesthesia, and they did not have any penetration of the globe. But it was mimicked as if they were getting an injection. And then the fellow eye of that sham participant would not get any treatment, would be a control. And so we move up in terms of hierarchically up the dosing curve. One important thing to mention here is that this study only included 1 injection at the start of participation for a participant. And so this was a single dose study. It did not involve multiple doses yet. And the reason why we chose that was that we wanted to see, hopefully, the onset of an effect, a maintenance of the effect, and then a waning down of the effect. Because just that cycle will allow us to be able to figure out how frequently we should be actually dosing within the trials as well, as we think about the next stage of the trials. So these are the summary of the trial results. I'm really delighted to say that the trial met all of its key objectives. We know from the safety of the drug so far that this drug seems to be very well tolerated by patients. We did not see any serious adverse events that were noted by any patients. And importantly, we have seen enough evidence here for what we call clinical proof of concept, which basically means that there is enough effectiveness that's been shown by multiple outcome measures to be able to convince us that, yes, we want to move forward into the next stage of the program now. And I will go into this in much more detail in subsequent slides. And importantly, all of the key objectives of the trial, such as trying to find out the ideal outcome measures, we've identified. We've identified also the ideal dosing and the dosing interval as well, and also the target patient population that we want to take forward as well. So really, I'm delighted to say that we're already making plans to starting a phase 2/3 or pivotal or registrational trial, and we're going to be hopefully starting that by the year end this year. So let's then dive into the efficacy or effectiveness of the drug. Now, it's important to think about one particular outcome measure called visual acuity, sometimes called best corrected visual acuity. And it's important because this is the outcome measure that is most commonly used in ophthalmology trials. And I'd like to spend just a moment or two just explaining what we mean by visual acuity. Visual acuity is essentially your central vision. For example, if you're reading or writing or watching the television, you're using your central visual acuity for that. And the way we typically measure it is when you go to your optometrist, he puts up a Snellen visual acuity chart, like you have on the left-hand side, of a single letter at the top and multiple letters going down to the bottom. And that measures how well you can see in that central vision. Now, it's known in research that unfortunately that Snellen visual acuity chart has got some inaccuracies associated with it, and it's not meant for clinical trials. The regulatory agencies, such as the FDA or the European agencies, prefer us to use the chart on the right-hand side that you can see, which is known as the ETDRS chart, or the Early Treatment of Diabetic Retinopathy Study chart. And that chart is different because you'll see that actually it has 5 letters on each line, not just a single letter at the top and then more letters as you go down, but 5 letters on each line. So it's standardized, and there are 14 lines in total. And so it's a standardized measure of how well a patient can see. And so this is the chart that we tend to use for all clinical trials. And so that's the gold standard for measuring your central vision in clinical trials. And so if you look at the study in the STELLAR program, we looked at this best corrected visual acuity, or BCVA as it's abbreviated. And essentially, we followed patients who were treated and untreated and looked at how well their central vision was doing over a period of time. And what this chart, what this graph shows is that over a 1-year period of time, patients who had QR41A treatment maintained their central vision, as opposed to the control eyes, the fellow eyes that did not have treatment, that waned away with their vision. Now, the waning away or worsening of the vision is given by the yellow line at the bottom, and that's in keeping with the natural history of the disease. So that ultimately there is a difference between the treated eyes and the untreated eyes of about 6 letters on that ETDRS chart. Now, is 6 letters important? Well, we think it is, because this is, after, remember, just a single dose, and the test-retest variability that's there inherently with any kind of test is about 4 letters. So this is already beyond the test-retest variability of the particular test we're using. And many clinicians and experts out there believe that 6 letters is a clinically significant change already, especially in a rare disease and a slowly progressive disease like Usher syndrome or non-syndromic retinitis pigmentosa. So this is very encouraging data for us already. Now, as you look at the patients who are more likely to benefit from the drug, are those patients who have already lost vision at baseline. And this graph shows the data for those particular patient group of patients, which are 6 of those in total. And again, we're looking at vision as the outcome measure here. And in the green line, you can see again that in those high-risk patients who are losing vision, who are at the doorstep of really losing all vision, that we're able to maintain their vision in the green line right out to 1 year. Whereas the fellow eyes, which are untreated, lose even more vision, as you would normally expect as part of the natural history of the disease. Ultimately, we have a 9.3 letter benefit, which again is clinically significant. So this really fills us with a lot of enthusiasm that if we are able to replicate this in a bigger trial, in a phase 3 pivotal registrational trial, that indeed the drug will be looked on very favorably by the regulators. And remember, this is after just a single dose. We believe that actually if you give multiple doses, you can actually maintain that green line at perhaps a higher level, perhaps. We'll need to see that in the clinical trials to come. So the overall vision data was very, very important here, and actually fundamental to our thesis that actually this drug, we believe that this drug works. Now, what about other outcome measures? How could they be supportive here? Well, we look at something called optical coherence tomography and a particular layer called the ellipsoid zone. And this is the data that is given here. Optical coherence tomography is an instrument which actually looks at a cross-sectional view of the back of the eye, of the retina. And so you get an idea of all of the different layers of the retina in an image that's formed. And we can then look at that image and see how the different layers fare over a period of time in the drug-treated eyes as opposed to the untreated eyes. And that really helps us understand that structurally, is there anything materially going on where the drug-treated eyes are doing better than the untreated eyes? And indeed, this ellipsoid zone layer is known to be a particular layer in that particular cross-sectional view of the retina, which is meant to be able to show you the viability of the important cells, the photoreceptor cells at the back of the eye. So this ellipsoid zone is a critical layer to look at because it's a marker of an important cellular layer that governs your vision, ultimately. And what this graph does is it shows that actually we stabilize that particular layer. And so that's crucially important because in the untreated eyes, unfortunately, this layer dissipates and it gets less and less and less. So you lose more photoreceptors as time goes on as part of the disease, which is given in the yellow line. Whereas in the green line, in the QR41A treated eyes, you preserve the photoreceptors. And essentially, this is what the message is here. And that's a very important message because optical coherence tomography, or OCT, is an objective measure. It's not based on the patient's willingness or ability to hit certain buttons to say they can actually see things. This is an objective measure. It's a photographic scan that's taken at the back of the eye. And so independent of what the patient is actually seeing, this is objective verification that actually we are preserving the important cells, the photoreceptors at the back of the eye. And indeed, we have another outcome measure called microperimetry, which is another important measure that looks at your visual fields or the amount that you can see in the periphery, but focused in the central area of your vision. So this is mainly for the advanced patient population. And what it does is it shines light in the different zones in the central part of your vision and asks you the question as a patient whether you can actually see the light or not at different threshold levels of sensitivity and brightness. And so that's called microperimetry. And what this graph is showing is that we have a very favorable effect on the microperimetry, which is the light-seeing dots in the central zone. And that's again another good verification and support for our visual acuity outcome measure that we saw earlier. So these are now 3 different outcome measures that are moving in the same direction. And that's, the experts say is very important because it now shows that multiple outcome measures are moving in the right direction in favor of the drug-treated eyes compared to the untreated eyes. And that really helps to build confidence that the drug is doing something meaningful and beneficial at the back of the eye. So that was the vision endpoint. Now, what about participants who are much earlier in the disease, where their central vision is actually well preserved, but actually their visual fields is caving in slowly? So the ability for them to see the peripheral vision is now, unfortunately, being restricted. Well, we took that population, and we then wanted to look at the particular outcome measures that were relevant for that particular set of symptoms and signs there as well. And importantly, there's a particular measure called static perimetry, which is meant to be looking at those participants who have this constriction of their visual fields or their ability to see in the periphery. And static perimetry is essentially a tool that uses bright dots of different light intensities, and that's flashed at different parts of your periphery of your vision. And participants are asked to be able to say and comment whether they can see a light in the particular area, and that moves as the dots are actually flashed in the periphery of your vision. And so that's a good way of mapping out how well you can see in the periphery of your vision and what the light intensity is that you can see as well. And so that's the gold standard way of mapping out how well your periphery of your vision is doing at this stage. It's well recognized by clinicians as a way of looking at this particular feature. And indeed, the regulatory authorities are very keen on this as well. And one of the outcome measures that we use is a standard of improvement in your peripheral vision. And so this graph shows that actually, if you look at a certain threshold of improvement of light sensitivity that's there, if we look at that measure and look at the QR41A treated eyes, compare them to the untreated eyes, then more patients who are treated get that gain or benefit in their peripheral vision compared to the untreated eyes. So again, this is a very important and monumental set of data, because now, for the first time, at least in my career, I'm seeing that actually patients who have this peripheral vision loss can actually get a gain in their sensitivity again with the QR41A treated eyes. And if that is the case, and if we can show that that is the case in phase 3 trials, then that'll be a really significant outcome measure and be able to help patients in much earlier diseases as well. And this is accentuated in the specific population that actually could be benefiting. These are the earlier disease populations. The previous graph was in the all treated population. And so here in the early disease population, there are eight participants included in here. Then you can see that actually the curve in the green line is increased even more. And this is after a single injection. So this really fills us with a lot of confidence that with multiple injections, we can maintain the improvement for much longer over a period of time. Now we look at, of course, how many of the participants respond to this particular outcome measure as well. And in fact, there were, out of the 8 participants that were there in this particular early stage of the disease, 7 out of the 8 responded. So again, that fills us with a lot of confidence that actually the majority of the patients seem to be benefiting from this drug, including improvements of their peripheral vision status in terms of light sensitivity. Now, let's talk about safety. So QR41A was very well tolerated. We have now over 3,700 subject follow-up days, which is a huge amount for a rare disease like this and for a first-in-human study. And this spans across 2 years of follow-up for patients. So we have a lot of safety data that's amassed now. And I'm glad to say that even the experts looking at this, and even various expert committees, safety committees that look at this, have looked at the data and have really given us the thumbs up to say, so far this drug looks reasonably well tolerated, and that we can now move forward into the next stage of development, which is the pivotal or registrational studies. Importantly, like I said, that there is no serious adverse events noted and no signs of inflammation. Some people have previously commented on the fact that gene therapy is associated with a lot of inflammation, and RNA therapy, luckily we don't see any cases of inflammation so far. Now, cataracts or lens opacities or lens clouding is a feature of age. It can happen with a normal age-related change. And unfortunately, in patients with inherited retinal diseases, actually have a higher incidence of cataract formation as well. Up to about 50% of the patients actually can get that. And indeed, we did have one patient who had worsening of pre-existing cataracts in both eyes. And both of the cataracts needed operations. And typically we do an operation, very simple, 10-15 minute operation under local anesthesia, where we replace the cataract with an artificial plastic lens. And then that's one and done. And this patient had to have that done. And luckily, this patient did not see any detriment in their visual outcomes as a result of that cataract being operated on. And indeed, the investigator who was dealing with this patient actually did not deem it to be treatment related either. Now, there is also another condition called cystoid macular edema, which is essentially fluid at the back of the eye, fluid collection in the retina, which can cloud the vision for participants. And unfortunately, again, this is part of the natural history of the disease for patients who have inherited retinal diseases. And it occurs actually, in about 50% of the cases as well. We had no new occurring cases of this fluid collection at the back of the eye, but there was one participant who did have fluid collection at baseline that actually progressed during the study as they were given the treatment. Now, that was classified as mild, and it's being managed with topical eye drops. And indeed, it's very well controlled at this stage now. So let me summarize the phase 1-2 results in its entirety. So QR41A seems to be well tolerated so far. And so at least as we look at up to 2 years worth of data, most patients seem to have well tolerated this drug. We've now established that there are various measures of effectiveness that actually have led to a benefit for the patients. In the advanced disease patient population, where these participants are very advanced in their vision status and only a little bit of vision is left, we've seen that actually 100% of those patients benefit with the visual acuity outcome measure, and none of those benefited in the sham group of patients. In the early to moderate patient population, we've seen that actually we can see improvements in their peripheral participants in their peripheral vision can improve with their light sensitivity as measured by static perimetry. And importantly, other outcome measures are also moving in the right direction as well, which really gives us a lot of confidence as we think about the future. We've also identified the particular dosing regimen that we'd like to take forward and the dosing interval as well. And therefore, we have all of the information available for us now to be able to think about the next stage of development. And we've in fact had some very preliminary discussions with the regulators already to map out what the next set of studies could look like as well. And those will be phase 2-3 studies, as we call them. These will be pivotal studies or registrational studies, much bigger studies than we have seen so far. And in those studies, we will really try and establish definitively whether the drug is safe and well tolerated and whether the effectiveness of the drug is without question. And ultimately, that's the package that we will give to the regulatory bodies for suggestion and a proposal for approval of the drug. So, of course, the drug is still an investigational compound. It's important to say that at this stage, and not an approved drug yet at this stage. The two studies will be run concurrently, and we hope to start those by the end of the year. So, of course, finally, and probably most importantly, I'd like to acknowledge all of the patients, the participants, and the caregivers that have taken a lot of time and effort and energy in helping us with deriving the results that we have so far and being very helpful participants in this study itself. Of course, we couldn't have done this without the help of the investigators and the site staff as well. So I want to give particular credit to all of those people who've been involved in the study and want to thank you all for all of your participation in helping us move this whole platform forward. I think this is a really monumental set of results that we've got now. For the first time in patients who have Usher syndrome, non-syndromic RP, are we seeing data, actual clinical trial data, that is showing some sense of benefit. It's early days, it's an investigational drug, and we're not sure at this stage whether the drug is safe and effective, but actually these early data are very encouraging indeed, and fill us with a lot of optimism in terms of moving forward to the next phase of the trials. And we look forward to carrying those out in due course. So thank you very much for this.